Bonjour tout le monde. This is Yuka from the WHO Regional Office for Africa. Thank you very much joining this webinar on the continuity of the Essential Oral Health Service, Day 2. We will start this webinar in shortly, but before we will start this meeting, I just would like to remind the housekeeping. I think maybe most of the people is actually joining from the yesterday's meeting, but just in case, I just would like to remind. So housekeeping, this webinar will be recorded. Links to the record will be shared after the session. We invite you participate in the discussion by sharing your question in the chat box. And then the panelists, you are invited to answer in the chat as we go. For all the panelists, please mute yourself when you are not speaker. You can select English, French, or Portuguese using the button in the below of your Zoom. So as you see, you can find the interpretation button, right side. You can select the English or French or Portuguese as you wish. And then you can see the chat box. You can put your chat comment as you wish. And then you can find the Q&A box. You can raise your question as you want.
Hello, Shivam. Hello, Shivam.
Yes, sir.
Have we started? Because I'm not hearing anything.
Yes, sir. So we have started it, sir.
Yes, we already started, but like we just waiting 1 more minute to start.
Okay. Okay.
Yep.
Yeah, I'm not hearing anything either.
Okay.
Okay, sir.
So thank you very much. And then thank you very much waiting for starting this webinar. We'd like to start. But anyway, before we start again, we just like keep remind about like a housekeeping. So the webinar will be recorded. Links to the recording will be shared after the session. We invite you to participate in the discussion by sharing your question in the chat box. And then panelists are invited to answer in the chat as we go. For panelists, please mute yourself when you are not speaker. You can select English, French, or Portuguese from middle bottom. So as you see this slide, you can find the interpretation button in your Zoom view. And then you can find the chat box chat box here. And then you can find the Q&A. So if you have any question in terms of the panelist presentation, please feel free to put your question. So just for your information, yesterday we already mentioned that the specific objective of this webinar are introduce the contents of the new guidance on consideration for the provision of essential oral health service in the context of COVID-19. You can access this guidance using the WHO link. And then we introduce and discuss infection prevention and control, aerosol generating procedure, and personal protective equipment for the continuity of essential oral health service, share good practice within and beyond the African region, agree on the way forward to strengthen oral health promotion, oral disease prevention and control as part of the whole health system for Build Back Better. So I think many of you already joined yesterday's day one session. We mainly focus on the introduction of the guidance document and the critical point to maintain the essential oral health service. So Dr. Benoit actually joined and then introduced the WHO oral health guidance document in the context of COVID-19. And then our WHO Regional Office for Africa colleague, Dr. Patrick Abok, actually present the COVID-19 situation and the response in the WHO African region. And then Dr. Tarisis from our health system colleague present the maintain the essential health service in the context of COVID-19. And then I, Yuka Makino, oral health focal point in the WHO Regional Office for Africa, present the interim result of the rapid assessment of the current status of continuity of essential oral health service in the context of COVID-19. Afterwards, Dr. Landry Kabago from our regional office explained about IPC, infectious prevention control among general setting. And then the Professor Paulo Melo, World Dental Federation, FDI, and the University of Portugal introduced the IPC among especially oral healthcare setting. So I just reviewed the day first. What we discussed in terms of the issue is as a part of the preparedness and this COVID-19 globally, nationally, it is infection prevention control and risk communication and community engagement. Then every actually so during the especially IPC session, panelists emphasize that consideration of the transmission stage, availability of personal protective equipment, availability of humans, we need to prioritize the essential oral health service. For example, AGP or non-AGP or invasive versus minimum invasive procedure. We also need to triage patients based on the priority. For example, using the telemedicine and digital technology solution to conduct the online consultation. Avoid the infected by COVID-19. So we need to educate and engage community on essential and safe oral health care, train oral health care provider and primary health care worker by adapting the COVID-19 guidance and guideline. This is actually a critical discussion point from day one. So today, because yesterday we discussed much more focus on the WHO guidance and also critical point to maintain the continuity of essential health service, today we would like to utilize a case-based learning approach. So basically we're sharing the country experience. As you see, we have 5 countries representative from Kenya, Senegal, Thailand, United Kingdom, and Burkina Faso to understand what was, effective to continue essential health service. And also we would like to learn from them what was a challenge to continue the essential oral health service. And hopefully we can find the way forward to continue the essential oral health service in the context of COVID-19. Also try to find a way to build back better for oral health care system as a part of whole health system. So thank you very much for listening my small introduction. Now I'd like to introduce Dr. Miriam from the, Thank you very much. So now I'd like to introduce Dr. Miriam Murithi. I hope my pronunciation is fine, Dr. Miriam. And then I'd like to, yes, thank you very much. So I'd like to introduce her, present the issue and challenge, lesson learned for continuity of essential oral health service in Kenya. So Dr. Miriam, should I share my presentation or my screen to share your presentation? Over to you, Dr. Miriam.
Please share, please share.
Okay, so please wait a moment. Dr. Miriam, I hope this is the correct version.
It should be, thank you so much.
Okay, so Dr. Miriam, thank you very much. Over to you.
Okay, fine. Good afternoon, everyone. It's afternoon in Kenya. Maybe it's morning or evening in another place. I'll choose to share without using the video because the network is not very stable. But I'm Dr. Miriam from Kenya, and I'm going to present the continuity of essential oral health services in Kenya in the with respect to COVID. Next slide. I wanted to put Kenya into perspective on where it is in the map of Africa, because we've realized it matters who your neighbor is when it comes to the pandemic. Some countries where your neighbors may not be so vigilant, others are vigilant, and that affects what happens in a particular country. Next slide. So on the topic of continuity of essential health services, I'll talk about the epidemiology updates, including transmission classification, a description of the public health measures in Kenya, status of oral health management nationally, the situation on continuity of essential oral health services, and the measures taken to maintain essential health services, including oral health, then the issues and challenges in maintaining essential oral health services in the country. I'll share the current situation and the lessons learned plus recommendations. Next slide. So this is where we are in terms of numbers of those who are affected or in one way or another. The population of Kenya as per the 2019 census is 47.5 million. Those people we have managed to test as per the 25th of September when the slides were sent were that one 524,000, and the confirmed cases are 37,489. We have those ones who have recovered. Of course, it's a continuous, recovery is a continuous process. So of course now there are more. And we've lost 669 persons so far to COVID. Not necessarily to COVID, the ones who died when they were infected by COVID. Without postmortem, we do know that they actually died of COVID or whatever the other comorbidity was. And this translates to about 1.8% of death of those who have tested positive. We have about 945 infected health workers so far who have tested positive, but they are part of whatever is confirmed as positive. It is not an addition to that. And so far, 16 health workers have died. And it is on a positive note, we've not lost any dentists or any oral health worker. Next slide. So these are the places where COVID has been high, the hotspots of COVID in Kenya. It's mainly the two main cities. At the coast, we have Mombasa, and in the middle, we have Nairobi. And that is by the virtue of, that is where most of the international visitors come. Those are the places that have two international airports. That is where there is a very high population of people living even in informal sectors and also traveling a lot. The other hotspot are the borders, the border to the neighboring country. One of these is Tanzania, or it's written Kajiado, and the other one is Uganda. Maybe more testing taking place in those spots because of the people traveling in and out, but also having neighboring countries whose management protocols of COVID have been very different from ours. Next slide. So the measures taken by Kenya are not very different from what have been taken by other countries. So apart from the normal public health measures, the personal hygiene, the hand washing, the respiratory hygiene in coughing and sneezing, the contacts, the social distancing and isolation and quarantine. The first case of COVID was reported in Kenya on March 13th. And is a citizen who had traveled from the United States. So that is when now we knew we had COVID in the country, and the government took measures to try to contain or to control the spread or to other places. So by March 15th, there was suspension of all social gatherings, all cultural gatherings. The schools were closed and all learning institutions, and the religious activities were halted. So people couldn't go to church, couldn't go to the mosque, couldn't attend weddings, could not go to school or learning institutions. Then by March 25th, all flights were suspended, both local and internationally. And by April 5th, there was mandatory wearing of masks, which is still continuing, but we don't have much control over the quality of the mask that the general public wears, and the way it is worn varies from some people to the other. You find some of them wear with the nose out of the mask. So we know they are not being worn well, but there's that effort to make sure they wear masks, especially in public places. In April 6th, there was, the government instructed that there should be a curfew, a dusk to dawn curfew from 7 p.m. to 5 a.m. in the morning. Then there was, it's not necessarily cessation of movement like it is, like I put it, it was more restricted movement to the major cities, that is from Nairobi, Mombasa to go to the other places. So you couldn't move from either Mombasa, Kilifi or Nairobi to other places, which were actually the high spots I had highlighted in the map before. But essential movements like food and medical care and security continue to go into those places. Then as we got to understand the pandemic more, we have continued to lift, the government has continued to lift these restrictions. So by July 6th, the movement to the different places was opened up, and people could now attend places of worship with a restriction of 100 persons per time for only 1 hour of the meeting, and from ages 13 to 58. So children below age 13 cannot attend those services or those gatherings, and persons older than 58 years also could not attend the services. And the curfew was also extended from 9 to 4 a.m. Then by August 1st, we have now opened up international and local flights to have resumed, of course, with all the other measures in place. And by yesterday, now the curfew was pushed from 11 p.m. to 4 a.m. And the number of gatherings was moved from 100 to 200, or at that the capacity. So that if a room was being occupied by 15 people, now it can accommodate 5, whichever that space may be. But the schools still remain closed. Next slide. So I wanted to highlight the status of oral health, how it is managed at the national level, because it affects so much of what we do when a pandemic like this one comes through. So at the national level, we still do not have current guidelines on oral health. because the ones that are there expired in the year 2012. But we have a draft policy that we are being assisted technically by WHO, and it is advanced. We are hoping by maybe the end of the year we should have a policy. And you're also making the other guidelines. But I also wanted to highlight the strategies that affect oral health and where we are at the national level. At national universal health coverage strategy includes oral health in its care delivery package. It may not be a very comprehensive package, but it is there is oral health, and it is something to work with going forward. Then the national social insurance, which we call National Hospital Insurance Fund, also covers oral health for those who contribute. Still a small element of oral health, but something to build up to. The primary health care and maternal and child health include oral health. At the maternal and child booklet, health, we include health as one of the milestones to measure, and in primary health care as what should be taken care of, even as the other diseases are taken care of, using the primary health care principles. Oral health is also integrated with non-communicable diseases, and we are working hard to make sure that activities to do with promotion and disease prevention include oral health at all the times. Next slide. On the situation on continuity of essential oral health services, at the time that we declared that the pandemic had affected Kenya, the oral health services nearly came to a halt. There's nobody who knew how to go about the oral health, both the providers, the government, and the people who needed the care. And like I think most of the countries, I don't think we are alone in this one, there was a lot of confusion on what is supposed to be done where. So in order to continue to restore continuity, the Ministry of Health gave interim guidelines that indicated what services should be offered. And in as far as oral health was considered, we tried to define what emergency cases are, and that they are the only ones that could be attended to. And we specified the facilities that could attend to those emergencies. And most of them were F5 hospitals, which are basically the referral hospitals, the teaching and referral hospitals, and the private hospitals that were at that level. That time, they are the only ones who could manage, they are the only facilities that could manage to triage and had the proper understanding, in fact, in terms of the health personnel, to handle the pandemic without endangering themselves and the patients. So then the proper PPE protocols were also prepared in reference to World Health Organization, CDC, and other countries that had already experienced the pandemic, which were mainly China and Europe at that particular time. So triage and telemedicine stroke dentistry were recommended, and it worked to a big extent, but to a bigger population that cannot access a mobile device or know who to call, they were still left out. But the government also moved in speed and made a COVID response team and a COVID call center, and gave a specific number that anyone who needed to know anything about COVID would call, or anyone who was in distress in as far as wanting treatment would call, and then they would be directed on where to go. Then there was mass public awareness, including involving the media, both print and broadcasting and social media, to sensitize the public on the disease and how to protect themselves, and even on where to seek care in case they found themselves in a situation where they needed whatever type of care. Then there was capacity building on health workers of the same. Next slide. So on the measures taken by the government on maintaining essential health services, there were guidelines that were made by the Ministry of Health on continuity of essential health services, and oral health was included in that as an essential service. And I've picked this verbatim as is from the guidelines. So what we tried to emphasize is that the environment that dentists work or that dental practice is done is highly risky because of the generation of aerosols and the proximity to the patient, and therefore clinicians and patients and by extension the public was at risk. So we defined emergencies and urgent cases for this particular continuation, because we realized there is so much overlap between the urgent and the emergency cases, and we listed them down, the ones that had to be attended to, that could be attended to continue with essential services. And this is not very different from what the WHO guidelines stated. So they are then controlled bleeding, the cellulitis, the orofacial trauma, dental pain that is not amenable to medication, then trauma of or avulsion of anterior permanent teeth, and cancer in patients with compromised immunity. One of the difficulties we had is that there's so much untreated need in the country, so that everyone who presents in a clinic under normal circumstances presents with dental pain, which they have managed to control in other ways and it couldn't. So the number of people in pain was still so much. More or less the same like a normal working day, even when there is no COVID. So that one we are still trying to fight with, because we can't see as many as we were doing. But on the better side, we had less trauma, because the main cause of trauma that finds its way to the maxillofacial surgeon is a road traffic accident. And because of the restriction of movement, those accidents were much, much fewer. Next slide. On the issues and challenges in maintaining essential oral health services, we realized that oral health already had services even before the pandemic. We've always had challenges of inadequate workforce, of lack of infrastructure, of erratic supply of commodities, all resulting from low funding and low priority given to oral health. So the pandemic only compounded the issues that were already there. So if we continue to have inadequate qualified workforce in terms of numbers, in terms of skills, and in terms of distribution, then we have lack of PPEs across the health sector, but more in oral health because it is not considered a priority. Then there is still low understanding on the situation, including the mode of transmission, eliciting fear, doubt, and stigma, which was there more at the beginning, but it has still not gone completely. So we still have all those issues. Then there's lack of clearly defined essential package of health, which has not come out clearly what is an essential package of health in Kenya. So it makes it very difficult to plan, even when now there's a pandemic. Just like many other countries, we also don't have data that is enough to plan. And there's low priority by the decision makers on oral health. So that even when there are funds that are supposed to be directed to COVID, the pandemic, then oral health service is not one of those ones that the decision makers want to make like a priority. Next slide. So the current situation is where we are at now. There may be an increase in the number of those ones who are infected or those who have tested positive, but there is also better understanding of the disease, and there is more availability of the PPEs. And then there are also guidelines that have been made both nationally and internationally that people can use to try to reopen and know where they stand right now. So the confusion, I can say, has reduced by significantly. So therefore, this has made dental practice to slowly pick up. So the private clinics and the private facilities are fully functional. They're offering the whole range of dental services. And but still there is so much limited of the number of people who can visit those clinics. At first, because of limitation of movement, you couldn't get them because most of these clinics are in the major cities and urban areas. But there's also the limitation of access by costs and the distribution of these facilities. They are still far from quite a number of people even who could afford, but a majority of the people cannot afford. So the larger population still remains unattended to, and the vulnerable groups are even further disadvantaged. Public facilities only function depending on availability of supplies and PPEs.
Só funcionam se
of lack of access to oral health services right now. Next slide. So on the lessons learned and the recommendations, we have learned that oral health is an essential health service And we must strive going forward to treat it as such in terms of planning and what we want to put across, even in preparation for such situations like what we are in. We've also learned that oral health are more prone to disruption during such situations due to the nature of the procedures.
Estes serviços
déranger étant donné les
We need to do. So I think we've also learned that if we invested more in prevention, it would be a better approach going forward because we'll have less disease to treat, either under normal circumstances or when there's a pandemic. So the recommendations is that we need to have more funding going towards oral health. We need to improve infrastructure and endeavor to have adequate workforce in terms of skills, maybe including skills shifting, especially in the areas of health, on prevention and promotion of oral health, using non-oral health workers to augment the shortage or to make the shortage not so severe. There is need to emphasize on non-invasive dental procedures, especially in low research settings like ours, and need to modify the oral health infrastructure in order to cope with these kind of situations in future. And we also need to rethink our training or retraining the health workforce to be better prepared for a situation like this if it were to come. Next slide. Yeah, that is the match I've done. And then the next slide is a few of the references that I had looked into. Thank you so much.
Thank you very much, Dr. Miriam, your wonderful presentation. So actually, Kenya has followed the guidance which was introduced mentioned yesterday. However, due to the low prioritization of oral health, it seems difficult to implement the essential oral health service in the context of COVID-19. So as Dr. Miriam mentioned that oral health promotion and oral disease prevention is actually very important. And then the need for more funding for oral health, improved infrastructure, adequate workforce, consideration of task shifting is actually critical in the context of COVID-19 and beyond. So thank you very much, Dr. Miriam. So those who have any question in terms of the Dr. Miriam's presentation, please try to raise your question in using this Q&A box. So now I'd like to introduce Dr. Babaka from the Senegal. Dr. Babaka, are you there? Dr. Babaka, can you hear me? Dear attender, please wait a moment. I try to connect with Dr. Babaka. Professor Babaka, in case if you talk, you need to unmute by yourself.
Votre micro n'est pas branché, Dr. Babakar.
Your microphone is not connected, Dr. Babakar.
Là, ça doit être bon.
It should be okay now.
Dr. Babaka?
Babakar, on ne vous entend pas, s'il vous plaît. Est-ce que vous pouvez parler fort dans le micro?
We're not hearing you, Dr. Babakar. Can you speak loud into the microphone, please?
Non, on n'entend rien.
So in case, Dr. Babaka, if you're difficult to connect with laptop, maybe you can utilize your mobile phone and then I will show your presentation using my laptop. Over to you, Dr. Babaka.
Est-ce que vous pouvez vous connecter avec un téléphone mobile et elle va partager l'écran et vous allez faire la présentation.
Can you use your mobile phone and we'll try that as she shares your screen because we can't hear you this way.
Anyway, so thank you very much for participant. Before we introduce Dr. Babaka, because we do not want to lose your time, if you don't mind, we would like to introduce Dr. Piada from Thailand. Dr. Piada, is it okay for you to present now? Over to you, Dr. Piada.
Yes, I can.
Okay.
Yeah, I present now.
Yeah, thank you very much. So please wait a moment. I will prepare your presentation.
Yeah. So,
can you see my screen?
Yes. So I start my presentation now.
Yes, please.
Yes.
So actually, sorry, I have to introduce yourself. I'm so sorry. So I'd like to introduce Dr. Piada Prasetomon. She's the Chief Dental Officer of the Ministry of Public Health in Thailand. So as mentioned that not only within the region, we also invite the outside of a region calling as like a Dr. Piada to share their experience in terms of the continuity of essential health service in the context of the COVID-19. So Dr. Piada, over to you.
Yeah. Thank you, Dr. Yuka. Good evening, everybody. I'm Dr. Piyada Prasersom from Ministry of Public Health Thailand. Today, I would like to share a Thailand experience about our oral health service during the COVID-19 situation. So next, please. Dr. Yuka, next, please. Yeah. This slide shows the timeline of the incidence of COVID-19 in Thailand. Even parallel with the incident, parallel with the oral health service measure that we divided into 4 levels of outbreak in the lower part. Yeah. Stage 1 is imported case in January 2020. Thailand reported the first case of COVID-19 on the 13th January this year, and it is known to be the first confirmed case outside of China. And stage 2, limited local transmission for late January to late March. Thailand reported its first case of local transmission on 30 January. And then we established the Center of COVID-19 Situation Administration, we call CCSA, led by the Prime Minister to serve as a single command center in managing the COVID-19. However, the number of new cases rapidly increased and reached its peak in late March. Then we enter stage 3, widespread cluster cases during late March and April. The government decided to take a bold step in controlling further space by declaring a state of emergency on 26 March. Both mandatory and voluntary measures were implemented with the social campaigns to stay home, stop the virus, save the nation. Travel restrictions, both nationally and internationally, were enforced. A curfew started on the 3rd April, restricting all people from leaving their premises nationwide, and self-quarantine was mandatory nationwide. Under the universal health coverage, the Thai government also provided free of charge service to all COVID-19 patients, covering diagnostic, testing, and treatment as a means of control the spread of the virus. As a result, Thailand was able to flatten the COVID-19 curve by early May. Finally, we reached the recovery phase in May and beyond. In this phase, no new cases were detected for 44 consecutive days. The government decided to ease restrictions. On 8th July, the government announced that the first wave of the COVID-19 outbreak in Thailand have come to an end. In parallel, measures of other health services were performed. The Ministry of Public Health, MOPS, is collaborating with the dental professional organizations in Thailand like Thai Dental Council, Royal College of Dental Surgeons, Dental Faculty Consortium of Thailand, Private Dental Association of Thailand, Dental Institute, and Dental Association of Thailand. All of these organizations launches the guideline during the phase of COVID-19 outbreak. However, after we have tested the first wave of COVID-19 outbreak in Thailand, we summarized the oral health service measured in 4 levels: the pandemic phase, post-peak phase, and anticipated outbreak phase, and the new normal, which I will show you the detail in the following slide. Please, the next slide, please. Luca, next slide, please. Yeah. Measure of oral health services. The 4 levels of the measures during COVID-19. However, one measure that we focus on at every level is health literacy. The early action is to boost oral health literacy and confidence in the oral health service to the general public via various channels such as the daily live broadcasting of the COVID-19 and social media. Thailand launches knowledge about oral health self-care and the preparation before having oral health serving during the COVID-19 situation. Start with the level 4 pandemic phase. On the left slide, on the left of the slide is the most serious situation. We will use this level when the government declares a state of emergency, followed with level 3, active management of the outbreak, or the post-peak phase, when the situation improves with a lower incidence of a new case. And next, level 2, anticipated outbreak, when the number of COVID-19 cases have been controlled and no new local case was detected more than double of state quarantine or 28 days. Finally, the level 1, which is the preparatory phase to enter a new normal. Now I will show the oral health service measure of each level. At level 4, we provide only an emergency case, which is uncontrolled bleeding, severe infections, trauma. Additional measures should be included from the normal service before COVID-19, such as remote consultation to reduce congestion and prevent the disease from spreading in the dental clinics, screening and triaging, physical distancing, personal protective equipment PPE, pre-procedural bowdings, rubber dam in the possible procedure, clean air ventilation and standard precaution. The picture shows 3 types of PPE. Yeah, this one is the PPE default, and this one is a PPE. PPE, I cannot see the slide. This may be the maximum PPE, and the standard PPE, and then full PPE. So the picture shows that these 3 types of PPE at the level that we will use maximum PPE for all the health service in stage 4. And in the early phase of disease pandemic. Please, next slide. Next slide, please. Yeah. Next, level 3 or post-peak phase. Due to the low incidence of a new case, we screen and triage patient. By patient under investigation PUI for COVID-19 criteria into 2 groups. For PUI suspected case, the measure is similar to the previous level, which is only an emergency case and under maximum PPE. While non-PUI suspected case without RT-PCR test allows for an urgent procedure under full PPE and non-aerosol elective oral health service under standard PPE. However, if the non-PUI suspected case has a negative RT-PCR test, we will allow to all service under standard PPE. Next, please. The level 2. Considering that there has not been a case of local infections for 28 consecutive days, the confirmed cases have been mainly people entering Thailand from risk countries. So we screen and triage patients by risk assessment. The high risk and moderate risk allowed to emergency and urgent oral health service. However, the high risk is treated under maximum PPE, while the moderate risk is treated under full PPE. The low risk allows for all procedure under standard PPE. Next, please. We are going to be a new normal in oral health service now for the level 1. Even though there is no evidence of a global outbreak, oral health service could not be the same. This is the preparatory phase to enter a new normal era. The new normal of oral health service in Thailand is 3S and 2 safety. The 3S that we have to change are staff, system, and structure. 2P safety is health personnel and patient safety. Staff means all oral health staff have to improve their knowledge and skill for full-handed dentistry, standard precaution, using high volume suction, and wearing PPE. System means administrative control such as less walk-in, more appointment patients, using technology for remote consultation, physical distancing in waiting area, screening and triaging for both oral health service and communicable disease, using a pre-operative mouth rings, rubber dam, and standard precaution on a regular basis. Structures means environmental and engineering control such as high volume suction and air ventilation system. The MOPS also launched a new design of the dental unit that concerns more about the ventilation system. Finally, please. Next, please, Yuka. Yeah. What we have learned from our COVID-19 in Thailand, and our recommendation is that early action and strong public health measure. CCSA is a whole of government approach led by top political leaders right before the peak of the first wave, which is also important. Strong public health measure and campaigns of hand hygiene, social distancing, and the universal use of face masks helped to hammer down the first wave. Second, Thailand has achieved universal health coverage since 2002. During the COVID-19 outbreak, the Thai government has provided essential health care to all COVID-19 people without financial barriers. And the MOPH cooperated with public and private dentists to find the proper and safe measure during the COVID-19 outbreak. We discussed from several points of view and expand more networks to other professions such as engineer, for consulting the air ventilation. Due to COVID-19, it's a very new situation for Thailand for dental personnel and most dental clinics. Pausing the business during the pandemic, many innovations for oral health service are created. And lastly, the government should communicate essential information about oral health services and self-care to the public, and repeatedly motivate healthy behaviors via several channels. The MOPH provides the situation update and knowledge of the COVID-19 daily through live broadcasting, which includes oral health issues. That's all from our Thailand now. Thank you very much.
Dr. Piada, thank you very much for your wonderful information and presentation, including stepwise risk-based approach for providing the oral health service based on the epidemiological situation, as well as defining the PPE by full, standard, and maximum.
Maximum, yes.
Yeah, and also including the clear algorithm of patient management. It is very, very, appreciated to share your country's experience. Thank you very much. So, as like yesterday, we are a bit behind of the schedule, but let's check the question coming from the participant. Yes, so Dr. Miriam, actually, I've noticed one question from Dr. Amy. Dr. Miriam, does this, for example, testing strategy include the oral health dental care worker? Actually, who is considered a high risk? Over to you, Dr. Miriam.
Okay, fine. Unfortunately, we don't test all of them. At first, the people who are working in the COVID isolation centers were being tested. And then I think the government got overwhelmed by lack of testing kits and wondering, do we test the health workers, all of them, or do we contact trace and test those ones? So it has not been happening for the health workers, unfortunately. But nowadays they test, if you have symptoms that are pointing towards COVID, then you are tested. I hope I've answered him.
Yeah, thank you very much, Dr. Miriam. So actually, I have a question with Dr. Piada in terms of the Thai service, because you said that you provided treatment free of charge, ensuring that treatment Thai government utilized, and also securing oral health budget. What kind of scheme are utilized? For example, whether you utilize a Health Promotion Foundation to secure the oral health budget. Over to you, Dr. Piada.
Pardon, I cannot hear your question. Please again. The signal is not good. Yes. Yeah.
Yeah. Can you hear me now?
Yes.
Yes. So you say that Thai government provide treatment free of charge. Ensuring the treatment free of charge, what kind of financing scheme your government use? As well as for securing oral health budget, what kind of funding, scheme, for example, Health Promotion Foundation, to be utilized in Thailand? I hope it is clear. Over to you, Dr. Piada.
In Thailand, oral health are already in the scheme of USC. So in this situation, it's the same. Our people still have their right to receive all the oral health essential services in USC. But for the suspected case, or for the PUI case, or also for the COVID-19, they will be treated. All the budget is for the USC office. They will pay for the hospital or for the laboratory for all the tests or all the treatment. They will pay directly from the office to the hospital and to the lab. And after all the COVID-19 cases are safe, they were safe, we can provide oral health as I have said. But in the condition that just only for emergency and urgency, if there's still the suspected case, my answer clear or not? It means that we also have our budget as normal. And for the health promotion, also the USC have a budget for health promotion and prevention. And we can use that budget to distribute all the information to our people. And for the Thai Health Foundation, Thai Health Promotion Foundation, they also give more budget and also have some message that they broadcast for all the people over Thailand how to protect themselves from the COVID-19 that I have said that we have the campaigns campaign to stay home and save our nation, something like that, wear masks. So this is a routinely every day, daily now in Thailand that we have this campaign in the public media. So it's no problem about budgets for the oral health services.
So thank you very much, Dr. Piada. This, comprehensive answer. So it means that actually the budgets is actually centralization under the UHC, and then oral health is actually integrated into the UHC. Therefore, the budget is secure for oral health.
Yes.
And also the oral health, the Health Promotion Foundation actually secure for budget for USC, including health promotion, oral health promotion perspective as well.
Yeah.
Thank you very much for this clarification. So I'm so sorry that I think many people would like to raise a question, but I would like to encourage Dr. Miriam and Dr. Piada to use the chat box to answer the question raised in the Q&A box. Thank you very much. So next, I hope Dr. Babaka, are you connecting now, Dr. Babaka?
Yes.
Yep, thank you very much. So now we'd like to move to the next session. I'd like to introduce both actually professors from the university. First speaker is Dr. Babaka Tamba, University of Dakar, Senegal. So he will present about the IPC issue in dental school, oral health setting. So Professor Babaka, over to you. I will share my screen to present your presentation. Please wait a moment, Professor Babaka.
Yes. Hello?
Yes, we can hear you.
Yes. La présentation.
Docteur
Oui,
Yuka
oui,
va
oui,
partager la présentation.
Oui.
Vous pouvez envoyer, c'est bon. Vous pouvez envoyer la présentation, s'il vous plaît.
Oui,
Please share the presentation.
je veux partager.
Oui, d'accord.
C'est bon? Professeur?
Yes.
Oui. So allez-y, s'il vous plaît.
Okay, thank you very much. Bonjour. Je vais m'exprimer.
Good afternoon. I shall speak French, but the presentation is in English. I have the honor of presenting the case of Senegal with regard to COVID and care at the dental school and hospitals. This is the outline. First, we have the mode of transmission during care. And then after that, we shall look at the measures taken by the Ministry of Health. Thereafter, we shall present care, dental care in the dental school during the COVID case, and then we will make recommendations before concluding. Next slide, please. In Senegal, well, first, in Africa, the first case was seen in Egypt. And in Senegal, the first imported case was on 2nd of March. On the 14th of March, universities were closed. Teaching stopped at the university and the teaching hospitals, as well as in the hospitals. As well as the reference hospital where the students went for their internship. Next slide, please. In Senegal, at the moment, we have had 2,400 cases being treated. There's a concentration of cases in Dakar, Thiès. Next slide. We have two types of transmission. We have airborne transmission with droplets that get in through the eye, nose, and mouth, and then indirect transmission from the hands. The Ministry of Health set up programs to control this infection in dental centers. They include coming up with guidelines and procedures, preparing a situation analysis with a needs assessment for dental clinics, and then the guidelines of the WHO were shared in terms of care at dental centers. And then the state also supervises dental services. At central level, that's at level 3 of care, we have a WhatsApp group to enable practitioners discuss. There are 248 participants who exchange and discuss cases so that they can take care of cases remotely. The pathologies that are not urgent are not taken care of. It is the cases of trauma, such as facial trauma, are discussed. Infections also were taken care of in the dental centers. We also gave guidelines in terms of how to care for such cases. At the reference hospital in Grand Yoff, we respected physical distancing. And we ensured that masks and PPEs were made available, as well as alcoholic solutions, which were used on patients. Partners also helped us so that we were able to procure PPEs, that is the laboratories, as well as the Ministry of Health and the Union of Dental Surgeons. They provided us with these facilities, even to the most remote parts of the country. So they were made available to dental surgeons all over the country. Masks and masks were prepared and manufactured locally, as well as face shields to ensure that activities can continue at the referral hospital. Dental surgeons were therefore provided with PPE so that they can attend to emergency cases. The protocols prepared by the Ministry of Health made it possible to work all over the country as far as the public centers were concerned. At the referral hospital, we received patients that had serious infections, as well as those that had orofacial and dental trauma. The protocols were respected, and disinfection of the mouth with antiseptic solutions were used alongside other measures when emergency cases were taken care of. This has been the case since the 2nd of March. At the dental school of Dakar, where about 30 dental surgeons are being trained, measures were taken by the management and the Ministry of Health to provide personal protective equipment. The protocols were also respected by the students in the 4th and 5th years of dental studies. So the protocols covered the arrival of this patient all the way up to treatment. We also reduced the number of staff. Those that were working before COVID were allowed to leave, and then the students were divided into 2 so that we also ensured that we had a maximum of 5 to 10 per group. At the entrance to the building, we put hand washing measures in place for the students, that is the 4th and 5th year students. Those students had their PPE, and then for these patients, we ensured physical distancing and insisted on them wearing masks. Measures were also taken, such as isolation if a patient tested positive. Then we had hand wash and basins made available, as well as waste disposal facilities. At the clinic, the patients took on the patients, taken with full respect of physical distancing, and devices were used to avoid being touched by saliva from the patients, rather. In terms of recommendations with respect to the staff, we recommend that the good practices continue even after COVID, because it's quite possible that the patient has HIV or tuberculosis. We also recommend that treatment with aerosols should change the mode of care. Patients also should be sensitized and made aware of the risks so that they can pass on the information they learn to the population. We also recommend that physical distancing be respected between and patients. We also recommend that other measures and protection equipment be used with the equipment. Disinfection between sessions should also be carried out. And finally, when the patients are interrogated, when they come in, we should check for signs of COVID. With the surveys that we are carrying out, the signs would include the various signs that they can see in the mouth. So the various signs of candidiasis, etc., can be seen in the mouth. Any such signs seen in the patient should be double checked. To the authorities, that is the Ministry of Health and the hospital administration, as well as the training, as the teaching hospital, we recommend that students should be trained in IPC. Then the country should be provided with adequate quantities of PPE for the teaching hospitals, universities, and public facilities. And also, there is need for further clinical investigation for oral conditions so that urgent cases can be taken care of and COVID positive patients who have emergencies can be attended to. We thank you for your kind attention. This is a presentation from the institute that takes care of all of these issues. Thank you for your kind attention.
Thank you very much, Dr. Babaka, Professor Babaka. This is very, very interesting information, including the WhatsApp screening and also utilize partnership to secure personal protective equipment and also local production of PPE, and also develop the protocol to opening the dental school and dental school hospital. So for the participant, if you have any question, please try to raise your question in the Q&A box. And then Dr. Babaka, if you can answer Q&A, please try to type into the Q&A. Thank you very much. So we are a bit behind of the schedule, but like we hope we can complete our session maybe within 30 or 40 minutes. But anyway, I'd like to introduce Professor Jeremy Bagg from the University of Glasgow. He will introduce about the maintain the essential oral health service in the Scotland. And also, actually, before we will organize a webinar, we asked our Chief Dental Officer in African community what kind of information would be helpful or useful. And actually, one of the point is they are struggling to opening the dental school. Therefore, we also request Professor Jeremy to provide the information how they open the dental school. And also, University of Glasgow have a project called Maldent. Actually, they collaborate with the Malawi University to open the dental school. So over to you, Dr. Jeremy. Hope you can share your screen.
Yeah, thank you, Yuka. Yeah, there we are. Let me just try and get the screen sharing going. I'm nearly there, I think. Can you see my screen?
I think you, actually the previous time is fine, but like now you share your speaker's screen.
No, okay, I can, I think I can put that right. Is that better?
Yes, this is better. Thank you very much, Professor Jeremy. Over to you.
Okay, let's go back to the beginning. Well, thanks very much, Dr. Makino and your colleagues for inviting me to speak briefly about the situation in the UK, but with particular attention to Scotland, which is where I work. So greetings from Scotland. This is a picture of our university tower and much of the city roundabout where I work. I thought, first of all, just say a little bit about the epidemiology in the UK at the present time. As with so many of the other speakers, the problems for us started in March. Some of the countries we've heard from, I know it started a little earlier, for example, in Thailand. I've just compared on this slide the coronavirus alert levels that we work to in the UK compared with the WHO criteria. So this is a WHO event. And we are currently in and around community transmission phase, and we have been for a good while now. And just to give you the chronology of what's been happening in the United Kingdom, on the 19th of June this year, the alert level dropped down from a level 4 to level 3 because the numbers of cases were dropping significantly. But I'll show you on the next couple of slides, things are taking a bit of a turn for the worse at the moment, as they have been in many European countries. And on the 21st of September, our alert level was adjusted back up to level 4. So we're at a stage at the moment where cases are going back up again. There is a big study in the UK called the COVID symptom study, led by one of the London universities, where we have an app, and each day we log in whether we've had a test and how we're feeling. And on the basis of that, on the 22nd of September, which is when I was writing this talk, the number of new infections per day in the UK was put at 11,867. And so the daily number of new cases per million across the UK varied from 2.4 to 118.4 per 100,000. And one of the issues at the minute in the United Kingdom is that it varies greatly by region. And what the government is doing is increasing lockdown measures in specific areas. So for example, where I am at the moment, in the west of Scotland, we've had additional sort of lockdown measures for the last three weeks or so. And most recently, that's now been operating across the whole of Scotland as of Friday. So things are really tightening up. Same in the northeast of England. So if we just look at this graphically, starting from January, looking at the numbers of cases confirmed, these are confirmed cases, confirmed by test. You can see the dramatic rise. This is when we're all in lockdown. And this testing was targeted testing. It was people who were actually symptomatic. Subsequently, mass testing was introduced. The numbers continued to drop. Sorry, my mistake. But more recently, they have started to go up again quite significantly. And the worry, therefore, is that we're heading into what people have called a second wave. We've been watching very closely what's happening in countries like France and Spain, where the situation is becoming more serious. And so we're at really quite a difficult stage in the trajectory of this pandemic. And of course, that complicates things like planning dental services and getting dental schools back to business. What's been interesting, though, in Europe, and what we're seeing in the UK at the present time at least, is that while the number of cases is going up significantly, the number of hospital admissions and the number of deaths are remaining mercifully at this stage fairly low. And it's thought that part of the reason for that is that the latest wave of infections is largely among much younger people, particularly sort of 17 to 24-year-olds. One of the challenges that poses for us in universities, of course, is that that's the age of university students. And currently in the UK, we're going through a real problem. We've got large numbers of students coming back to university, sharing facilities in halls of residence, and we now have outbreaks in 40 different universities in halls of residence, including our own University of Glasgow. So that's a real challenge for all of us who are trying to run university courses. So we anticipate that for the next 6 months at least, we're going to have to maintain these much tougher restrictions. Just to give you some feel of the numbers of cases and the rates across the different parts of the United Kingdom, England clearly the largest portion of the United Kingdom. Here is Scotland. And what we're working out in these last two columns are the average numbers of cases per 100,000. But from a dental perspective, particularly interesting is the average number of asymptomatic patients per 100,000. And the reason I mention that is that, of course, one can do the triage and ensure that patients coming for dental treatment haven't got a recent cough, haven't got fever and so on. But we know that probably at least 20% of patients with this infection are asymptomatic. And the worry for dentists in this country has been that if they're treating asymptomatic patients who they don't realize are infected, then they're putting themselves at risk, and also, of course, other patients at risk. And what this figure shows really is that these numbers of asymptomatic patients are really extremely low, even though the number of cases across the population is going up. And it's very important to keep that in mind, I think, and to maintain some perspective on the risks in the context of patients being treated by dentists. So this is the timeline for Scotland. My colleagues and other speakers have been showing the various timelines. So what happened in the UK was that on the 17th of March, all aerosol generating procedures ceased. And then shortly after that, on the 23rd of March, all routine face-to-face dentistry ceased. It was a very sudden, abrupt change, and it was very challenging for all those involved in delivery of dental care, and also, of course, for patients. And so teledentistry was used extensively, and what dental practices would do would be to provide advice using the 3 A's, which I know is mentioned in the WHO documentation. And we also set up urgent dental treatment centres, or urgent dental care centres. This happened across Scotland, but it happened across the rest of the United Kingdom, where urgent cases were treated by staff wearing full PPE with all the appropriate precautions. Now, in terms of trying to get dentistry back on its feet, on the 22nd of June in Scotland, practices opened for face-to-face consultations, but only for urgent care and only for treatments that didn't require aerosol generating procedures. On the 13th of July, it relaxed a bit more, and the practices were allowed to do routine care, not just urgent care, that could be provided without aerosol generation. And then on the 17th of August, it opened up pretty much fully, so that aerosol generating procedures were permitted, but there was a requirement for full PPE. And just as in other countries, there have been issues around supply of PPE in the UK, but also other aspects of transmission-based infection control precautions, such as the requirement for a fallow period between patients if an aerosol generating procedure has been carried out. And in many practices, that the fallow period that's been required is 1 hour before you can clean the surgery. So you can imagine the impact on the productivity of a practice that may be used to seeing 25 or 30 patients a day, can only maybe now see 8. So that's an ongoing big issue, and I'll come back to that later. Now, if we just look at what impact that has had on the continuity of the oral health service in Scotland, these are data that were kindly provided for us by Public Health Scotland through in Edinburgh. You can see that from March, the number of total adult patient contacts and the number of child patient contacts just fell off a cliff. It was a very, very sudden and dramatic drop. We have data for all sorts of different types of treatment, but if we just look at the common fillings and extractions, again, you can see that same pattern with a precipitous drop reduction in the number of dental treatment procedures. Now, I don't have data past the July. It takes a long time for these centralized data to be put together by the government. It is picking up, but we know that it hasn't picked up to anything like pre-March levels. So there is still difficulties for many patients in the UK who rely on NHS treatment as opposed to private treatment in getting access to the care that they need. And just another illustration of this, I'm sorry the yellow probably doesn't show very well, but these are data from the Scottish Emergency Dental Service. So this is the emergency service out of hours and at weekends. And you can see that the number of calls to that service went up from 20th of March, about 3,500, up to over 7,000 by May. It's starting to drop off now that there is some resumption of dental practice. Now, the issue with the 3As, of course, is that in many ways it was a delaying tactic. It wasn't that there was anything else really we could do, but of course it went against really all the rules of antimicrobial drug stewardship. And we were very interested to get these data again from Public Health Scotland through the PRISM system, which shows what happened to antibiotic prescribing once we went into that lockdown period. And the problem is that for many of these patients, the antibiotics may have worked temporarily, but in the long term, they haven't worked. Some patients have had multiple courses of antibiotics, and ultimately they need the surgical treatment that they should have had in the first place. So this is, again, I think, quite problematic. Now, Dr. Makino asked me specifically to talk a little bit about the challenge for dental schools. And you may have thought, Yuka, that I would have all the answers. I'm afraid I don't have all the answers at all, because it is extremely challenging. As head of a dental school, I'm having a lot of sleepless nights at the moment. So what happened was that on the 23rd of March this year, all of the United Kingdom dental schools stopped doing face-to-face teaching. Everything went online. And that included ceasing clinical teaching. And of course, dental students need to spend a lot of time treating patients as part of their course. And so really since last March, most of our students have been able to do nothing in terms of clinical care of patients. So all of the teaching and the assessments, the exams in the summer, all had to be done online. This image here is of myself with a group of my staff preparing to do a virtual OSCE examination for our third year dental students. And we were very fortunate that we had all this digital technology. If this pandemic had come 30 years ago, I have no idea how we would have managed even as well as we have. Now, one of the ways that dental schools then are looking at trying to get around this is to do a lot more dental simulation teaching. And from June, late June this year, we have been able to bring students in limited numbers with social distancing back into our preclinical skills facility. But as you'll all know, drilling a plastic tooth is very different from actually caring for a patient. And so there is a limit to how much we will be able to maintain students' clinical competence with simulation. And of course, our professional regulator, the General Dental Council, will also insist that these students, before they graduate, have had sufficient clinical contact. Now, in terms of actual clinical teaching, small numbers of our senior students in the 5th year of the course have started to go to the outreach facilities, but very limited numbers. And at the moment, they're doing no aerosol generating procedures. So this is since March. And these are students who are due to graduate as what we call safe beginners, using GDC parlance, next summer. So we're actually potentially facing the challenge that if we can't graduate our current BDS5 cohort of students and they can't move out of the course, then we won't have any capacity to take in a new BDS1 group in 2021, or for any of the students in the course to actually progress to the next year. And that is a huge headache. And in fact, I have to go and address our principal and senior management group at 3 o'clock today to discuss the challenges that this is posing for us and for the university. One of the other major challenges, of course, for many dental schools, if not all, is that we teach our students in open plan polyclinics. And the issue there is around control of aerosols, ventilation, air quality, and so on. And jury's out at the minute in the UK on how we're going to be able to get back to doing aerosol generating procedures in these types of teaching environment. And since a huge volume of our clinical teaching facilities in dental schools are open plan of this type, so that we can supervise the students properly, that is a continuing headache. Now, just before I move on to talk a little bit about the Maldent project, I just want to mention this document. Some of you may have heard of the Scottish Dental Clinical Effectiveness Programme. It operates as part of our postgraduate deanery, NHS Education for Scotland. And I've recently finished 3 months of chairing a rapid review group with Jan Clarkson and her central team, looking at aspects of mitigation of aerosol generating procedures in dentistry. How can we get dentistry back on its feet, but also maintain safety of patients and staff? So we had a multidisciplinary working group on this, including people like particle physicists. We had an aerobiologist, many people from different branches of dentistry, and it was supported by the Cochrane Oral Health Group in Manchester. This is not guidance, this is not official guidance, but what we have produced are a series of what are called considered judgments based on what limited evidence we have, and the evidence is really poor for most of these things like pre-procedural mouthwash and so on. But we published this just last Friday. I put the web link there if any of you are interested in looking at it, but it's aimed internationally. It's not just for the UK. And we hope that these considered judgments may be helpful to those who are having to prepare formal clinical guidance to be used by our professional teams. So finally then, just to say a little bit about the Maldent project, which I have to say over the last 3 or 4 years has probably become my main passion as an academic. This is a project which is funded by the Scottish Government, and it's a partnership between our own school here in Glasgow and the University of Malawi College of Medicine. And I'd really like to pay tribute to my colleagues at the College of Medicine, Dr. Mapatsu Mapando, the principal, Peter Chimimba, my equivalent number in Malawi as the Malawi lead, Dr. James Machenga, the new dean of the dental school there, and the whole team. It's a fantastic college to work with. And one of the main planned activities of this grant was to establish a BDS program in Malawi, and we succeeded in launching the program in August last year. If you're interested in reading more about the project, which isn't just about the dental school, it's also about work linked to developing an oral health policy for the country, and various issues linking to infrastructure and task shifting. We maintain a blog at themaldentproject.com, which is always kept pretty much up to date. And you would be able to learn a lot about the project if you went and had a look at the posts. These are the first group of students. 10 of these students are the BDS 1 students. They've gone into the first course of the BDS program, the first year of the BDS program. And some of them are on the foundation course at the College of Medicine, ready to join the next cohort of BDS students. And this was a photo shoot they arranged a few months ago, so it's a fantastic picture. Now, just to look at the contrast between how we were able in Glasgow to manage the teaching and learning of our students using digital devices with the challenges that were faced by the staff and this first cohort of students in Malawi. Of course, the big issue was that some of the students didn't have access to suitable digital devices. In fact, about a quarter of the students at the University of Malawi College of Medicine didn't have a suitable digital device. There are issues obviously around reliable Wi-Fi, particularly in some areas of the country, and data is extremely expensive in Malawi. But the good news at the end of this is that by a variety of means, it's been possible to purchase digital devices for those students who didn't have them. And the principal has been able to arrange a very good deal on data for the college from 1 or 2 of the data providers in the country, so that they're also able to provide these data bundles for the students. So we hope that COVID isn't going to hold those students up greatly in their studies, that we'll be able to get back to normality fairly soon. but it's an exciting story. So I'll leave it there. Thank you very much for listening. If you would like to contact me, my email address is there. I'm on Twitter, and similarly, the Maldent project is on Twitter too. But I think that's all from me, Yuka. Thanks very much indeed.
Thank you very much for Professor Jeremy for sharing very, very informative presentation, including the stepwise approach on the continuity of essential oral health service, opening dental school, and also Maldent project in Malawi. And also thank you very much for raising the characteristic of this COVID as like a symptomatic issue. And also it is very, interesting to understand about the increasing of prescription of the antibiotics. We need to think about like an antibiotical resistance issue under current situation. So unfortunately, we do not have enough time to discuss. Therefore, I would like to request Professor Babaka and Professor Jeremy, you have a lot of questions coming from our participants. Please try to answer those questions using the Q&A chat box. So I'd like to introduce our final presentation because actually through today's session, we much more focus on the government or public section, but as you know that the private dental section is quite important in our oral health community. Therefore, I'd like to introduce Dr. Ernesto. He's actually the private dentistry in Burkina Faso, and then he will share the experience of the continuity of essential oral health service by the private dentistry. Dr. Ernest, are you connecting? Over to you, Dr. Ernest. Can you hear us?
Oui, je vous entends.
Wait,
yes,
no.
I can hear you. Can you hear me?
Yes, I can hear you. So please try to start your presentation. Over to you, Dr. Ernest.
Bonjour tout le monde.
Good day, everyone. Good day, everyone. I'm Dr. Ernest Toé from Burkina Faso. I will briefly give you an overview of Burkina Faso. We're in a landlocked country in Central West Africa. The service area is 270,000 square kilometers squared. And in 2019, the census showed that we had 20.8 million inhabitants. The capital is Ouagadougou. And we have 76 dental care facilities or settings in the country, 20 in the private sector, and of that 17 are in Ouagadougou and 3 are in Bobo Dioulasso, our second city. In 2020, we identified that we had 101 dental service surgeons who were registered and also 200 auxiliary staff. This staff are dental assistants and nurses who are attached to oral health settings. On the 22nd of September 2020, we had a total number of 1,950 confirmed cases. 1,260 are cured, and we also recorded, unfortunately, 56 deaths. These statistics, this is at the 22nd of September. That is our record for the 56 deaths. With regard to this pandemic, on the 23rd of March 2020, our National Order of Dental Surgeons in Burkina Faso tried to take measures to limit the virus transmission in oral health settings. So they tried to put out the notice very quickly that a dental practice should never be responsible for disseminating or spreading COVID-19, because otherwise, if we don't identify this, we will be endangering patients and healthcare personnel through the risk of airborne infection. So this work with the National Order of Dental Surgeons was helping us to disseminate the information necessary of how to treat emergency cases, urgent cases, and so on. They also had recommendations on PPE, recommendations which the Ministry of Health also disseminated regarding measures such as social or physical distancing, hand hygiene, the 5 moments, and so on. Now, I'd just like to summarize the situation. Very quickly, we decided to stress the importance of having telephone consultations or appointments. The receptionist will ask the patient about the appointment to see whether it's urgent or not. On arrival, the receptionist takes the temperature using an infrared thermometer if possible, and also physical distancing is insisted on to avoid contact between the patients and to ensure that they only have essential appointments made. At the end of March, we completely shut down our dental health settings. But then we opened up again only for emergency or urgent cases. Patients also are systematically interviewed to check if they had any contact with a sick person or someone presenting symptoms such as fever, cough, shortness of breath, etc., altered taste, because very often patients aren't informed that such and such a sign or symptom can be COVID related. This also helps us to do a triage of patients. According to the recommendations that were drawn up by the Order of Dentists, those recommendations were of a general nature. I told you, I spoke about non-pharmaceutical measures and also posting leaflets at the entrance of all dentist practices. Then the second level is the monitoring of healthcare settings. We need to limit the activities that are ongoing. There needs to be regular and good ventilation of the spaces, particularly in the waiting areas and treatment rooms, and also to try and minimize aerolization by using suctioning at the right site. Now, the type of care that was provided were really emergency or urgent cases. The pulpitis, which is quite widespread, the inflammation of the dental pulp, which is quite difficult to bear, also abscesses and external infections, complications which could have arisen because of cavities and caries, also dental trauma. We use a lot of two-wheeled vehicles, and therefore we can have road traffic accidents, and people need to go and visit an emergency department because of this. And also significant bleeding. Now, the problems, solutions, and challenges, we need to look at the psychological impact on the health personnel in the clinic. Since the COVID emerged, we needed to look at the attitudes of the health carers. There was a lot of fear that they might have the disease. They also were wary of patients. I'm talking about the attitudes within the hospitals, and also the concern that they are not going to be sufficiently protected because they didn't really know how the disease could be transmitted. Also, families were fearful of the risk of being infected at the clinic. A lot of our brothers and sisters were saying that within a family, there might be a possibility of transmitting the disease, because at the clinic you are looking at a lot of patients there, and then you go home, and then what's going to happen? How do we protect our family members? The family members also need to be sensitized about the dangers involved. So this is a very important aspect that needs to be taken into consideration. Also, looking at the psychological impact on patients, they are also afraid of contacting the disease in the clinic and thinking that they might have to be admitted to a hospital. They are afraid of going to the clinics because they might contract the disease during the care that they are giving, or perhaps when they're in the waiting room in contact with other patients. There was also a lack of motivation or poor motivation of the health personnel to work. In spite of the protective measures, people needed to be reassured, especially with regard to the health personnel. I think that we haven't quite covered the impact, the financial impact. This is very important for our private clinics because there has been a fall in salaries and yet no decrease in fees and charges. Sometimes we have joint practices and the staffs have to be paid. So the financial implications were significant for running a practice. They still had to pay water and electricity bills. Because we suddenly had a problem in paying our different providers. In addition to these increasing costs, we also had problems in acquiring protective the PPEs, the masks, the shields, and so on, because that wasn't the normal material or equipment that we had in our dentist practices before. We also needed to purchase disinfectants, the ABHR dispensers, alcohol-based hand rubs, and liquid soap. These were additional costs that were not factored in. But by the end of March and the end of April, we were able to come up with funding for this important material so as to minimize the negative effects that would ensue otherwise. With regard to the way forward, we all need to work to adapt to the new practices. We need to have better investment in PPA, everything in terms of shields or visors, a better protection in treatment areas, and we also need to have easier and greater access to PPEs. Because even if we have the money to pay for it, sometimes getting access to them is problematic. So that's what I have to say with regards to the way forward. What are our conclusions? We know that dental practice will not be like it was before. We need new behavior and new techniques so as to have, for our consultations and appointments to be optimal. We try to have, we try and treat people during the same sessions so that we can reduce the number of appointments that patients need to make. Therefore, we need to optimize the appointments that we have. We also would like to ask WHO to support our practitioners with training and with upgrading and updating of information vis-a-vis the disease. because all the findings that they have, all the results they have will help us to do better at the local level. We also need to ensure that PPE are available and affordable. This is a very important issue because very often we have stockouts of PPE. The oral health profession must survive this pandemic, and indeed, it must maximize on best practices for the post-COVID area, as this time has highlighted to us the shortcomings that we have in our profession regarding protective measures. And on this note, I would like to thank you for your kind attention.
Thank you very much, Dr. Ernest. From the private dentistry perspective, I mean, like I noticed that the private dental clinic in the Burkina Faso actually following the guidance from the Ministry of Health on IPC, triage, ventilation, telephone consultation, and also thank you very much for raising for the issue or concern on the psychosocial effect of COVID on the both patient and also oral healthcare provider, and the financial impact for the oral healthcare provider. So thank you very much. Actually, we are really behind the schedule. Unfortunately, we do not have much time to discuss, but we still have a Q&A. So I'd like to encourage the expert to answer the question. So I might move to the final agenda. So please wait a moment. I hope you can see my screen. Can you see my screen?
Yes.
Yep, thank you very much. So actually 2 days, day one, we are, much more focused on WHO guidance or strategy. And then day two, we are learning from our colleagues from Senegal, Kenya, Burkina Faso, and also Thailand and the UK, Scotland. So in terms of the conclusion in the context of COVID-19, I just would like to raise the key critical point during this 2 days, session. So important point is as part of the strategic preparedness response COVID-19 plan, globally, regionally, nationally, it is important to strengthen the response to each pillar of COVID-19 plan, such as continuity of essential health service, infectious prevention and control, and risk communication and community engagement. The integration approach is critical. Need to integrate oral health as part of the essential health service during the COVID-19 with financial protection. Consideration of the transmission stage, availability of PPE, and availability of human resource need to prioritize the essential oral health service. We also need to triage patient based on the priority. We definitely ensure IPC by consideration of chain of infection, mode of transmission, and the characteristic of oral healthcare setting by securing and using appropriate PPE. I noticed that several persons raising about the partnership issue and also like a lack of PPE. For example, Dr. Babaka from Senegal, he mentioned that actually Senegal tried to develop the PPE really, innovative approach. So maybe each country also have a, the way forward is try to, develop like a, local facility to develop like own PPE, following the global guidance. And also need to educate and engage community using the telemedicine or digital technology on essential and safe oral health care during a pandemic. And also important point is we already have a plan or guidance. However, we need to train oral healthcare provider and primary care worker by adapting the COVID-19 guidance guideline in your country context. So next is actually conclusion for Build Back Better. So as mentioned that, for example, Dr. Miriam from Kenya, oral health, actually, everything is put in place, but like a low prioritization. Therefore, we need work hard for prioritization of oral health using the regional oral health strategy 2016 and 2029 in the WHO African region. Actually, this is adapted by like a minister of 47 member states in WHO Africa. So we definitely utilize this opportunity to prioritize oral health in our region. and also strengthen local resource mobilization. I hope Dr. Alex, during the closing remarks, if he provide any suggestion in terms of local resource mobilization, it would be really appreciated. And also we strengthen the oral health policy, strategy, action plan through inter-multi-sectorial collaboration to ensure population-based strategy with budget for oral health. Then we need to strengthen capacity of the oral health workforce because especially in African setting, we are not have much human resource for oral health. Therefore, we need to think about task shifting issue. Then we need to integrate oral health into UHC benefit package with financial risk protection, and then reinforcing integration of oral health into the existing surveillance system to understand the situation and plan better. And then we think we need to leverage oral health because actually many of the African countries already utilize e-health or m-health, and actually WHO planning to launch the oral health, so we can great opportunity utilize this oral health to strengthen the oral health. And then finally, establishment of the effective partnership, not only the research, but also, for example, resource mobilization and also securing the PPE. This is very important, commit to the Build Back Better. So thank you very much for your kind attention. So now we close to the end of the session. So I'd like to introduce Dr. Alex Tiandoke-Beogo. He is Acting Director of the Universal Health Coverage, Communicable, Non-Communicable Disease Cluster in the WHO Regional Office for Africa. Dr. Alex, over to you.
Bonjour, bonsoir, selon votre position. J'espère que vous m'entendez tous. J'ai le plaisir, au nom
Good afternoon. I have the pleasure on behalf of WHO Afro to take the floor for the closing address. First, I would like to congratulate you, all parties.
Intervenus pendant ces deux sessions de webinaire et qui ont grandement contribué au succès de ce webinaire. Je tiens également à remercier Yuka spécialement en tant qu'organisatrice principale de ces sessions, ainsi que les équipes du cluster IPR et de ECHO qui ont facilité
as well as the teams of this cluster for facilitating the exchange of experiences and best practices. Following these two sessions, I hope that you are all informed well enough so that you can continue medical, dental services under COVID-19 using the integrated and multisectoral approach, which is necessary for universal health coverage. What is missing now is what in French is resources, and especially financial resources. To ensure continuing of dental services, we need to mobilize necessary funding at both regional and country level so that we can make the most of domestic resources as well as any possible opportunities that we have. Starting with the COVID context, we know that this led to the slowdown in essential health services, but it is also the opportunity to raise resources through the funds made available for response in countries, as well as implementation of catch-up activities for some activities such as immunization, maternal and child health, etc. As Yuka pointed out, there is also the possibility of remote work and remote teaching these are things that we have had to do in the last few months as part of the new normal under COVID-19. We can also count on facilities made available to countries by some donors, such as the Global Fund, that authorized the use of about $50 million for inputs that are necessary for case management under COVID-19, and also for the procurement of PPE for healthcare workers. Other opportunities, such as the World Bank and Gavi, can also be used if we combine the oral health services with other essential health services. We can also take advantage of immunization campaigns, as well as the distribution of ITNs, as well as distribution of masks for neglected tropical diseases, to ensure sensitization on oral health and encourage the populations to avail themselves of these services. This reminds me of the period when I was a provincial health director in Burkina Faso at the end of the 1980s. I had a provincial oral health service in the regional hospital, which was supported by an NGO. With this NGO, we envisaged extending activities of the hospital dental center to the remote health centers in Burkina Faso. So we identified, in consultation with the nurses, the type of oral health that could be provided by them, and which types would be referred to the dental center. And they included promotion of hygiene and oral health through the use of toothpaste and toothbrushes or chewing sticks. And so we disseminated their use in the communities and schools. So we organized training by the team of the dental center for all the staff. And this was followed up with supervision. During the supervision, some of the equipment for minor surgeries were provided to all the health centers, and practical training was done on during the training for the use of this equipment. At the same time, we organized training in the various villages and schools on oral hygiene and the use of chewing sticks and toothbrushes. With the success of this project, I was given the opportunity to present this initiative during the World Dental Forum Congress in 1996 in Singapore. I would therefore like to urge you to use initiative to mobilize resources and to integrate oral health services into primary health services, so as to take advantage of the COVID-19 context to ensure that service continues. As I reiterate the availability of the regional office to support you within the limits of its capacity, I declare closed this webinar on oral health. See you soon. Please stay safe. Once again, I would also like to thank the interpreters who facilitated communication during this session. I thank you for your attention, and please stay safe.
Thank you very much, Dr. Alex. So after these closing remarks, our webinar is closed. So thank you very much for your participation, and thank you very much, panelists, and also translator, and also the ECHO team. Thank you very much. Have a lovely day.
Bye.
Bye-bye.
Bye-bye.
Bye-bye. Thank you very much.
Bye-bye.
Thank you.
Bye. Thank you.
Thank you very much.
Thank you, thank you, thank you.
Thank you very much.
Bye, Yuka.
Thank you, Dr. Piada. Bye-bye.
Bye.
Bye. À bientôt.
Thank you. Thank you. Bye-bye.
C'est moi, bye.